These are our objectives today. We're going to describe the implications of a neonate being infected with group beta strep and the interventions needed to prevent it. Discuss complications related to malpresentation. We're going to discuss the common intra-partum procedures that are used to facilitate birth, along with the indications and risks associated with each. Explain the indications, risks, and complications with cesarean birth. List the components and nursing considerations of a cesarean birth. Identify emergent complications that may arise during labor and birth and the nursing interventions required to address them. And we're going to discuss nursing care for a family that has experienced a perinatal loss. So before we get started, I'll just let you know, as far as nursing is concerned when it comes to labor and delivery, A1 standards suggest that in labor and delivery, the nurse and to patient ratio should be 1 to 1. That we should only take care of one laboring patient at a time. People who have never worked labor and delivery don't quite understand that patient ratio, especially if you're on the floor like med-surg or postpartum where you may have 5, 6, 7, 8 patients. But whenever you find yourself in the labor and delivery atmosphere, you can see why it's important to stay 1 to 1. The hospital I work at here in the city, we try really hard to adhere to A1 standards. It's not always possible. Depends on the patient census, but we never take care of more than 2 laboring patients at a time, ever, okay? And if it's a cesarean section, it's only 1 to 1, always, until that patient is recovered into postpartum, okay? Starting with group beta strep, okay. So, group beta strep is often asymptomatic for patients, but it can be devastating for infants. Signs and symptoms of group beta strep infection in neonates include sepsis, pneumonia, and meningitis. Up to 40% of patients are colonized with group beta strep. It's benign outside of pregnancy. This is not an STD, okay? This is very common for women to be colonized with group beta strep. It's asymptomatic. It's not a problem for you to have group beta strep when you're not pregnant and expecting a baby. Generally, we don't know that we're colonized with group beta strep outside of pregnancy. But all patients are going to be swabbed vaginally and rectally between 35 to 37 weeks gestation so that we can be aware if their group beta strep is positive or negative. Patients with group beta strep positive urine or have had infants who developed GBS previously are automatically treated. If a patient goes into labor before being tested, she's going to be treated prophylactically. So if we don't know her group beta strep status, we're going to automatically treat her with antibiotics. Patients who have premature rupture of membranes are also going to be treated prophylactically. So, you know, a preterm, say someone ruptures at 27 weeks, we're going to start antibiotics on her and continue those antibiotics for probably 7 days. Prophylactically, and then whenever she does deliver, we'll start antibiotics again, okay? Treatment is not indicated for infants being born via scheduled cesarean section. So what we're seeing now is that doctors aren't even swabbing their scheduled C-section patients. So patients who've had a C-section before and they're coming in for their repeat C-sections, they don't need a swab because we're not really worried about them transferring that to the baby. It's more so the concern is during labor for a mother, a baby passing through the birth canal. It is dangerous for the newborn during labor. If an infant is born vaginally from the mother who is not treated for group beta strep, the effects can be devastating, including sepsis, pneumonia, meningitis. You can see group beta strep sepsis pretty quickly. Infants can die within 24 hours of birth. Antibiotics are started at the time of the start of labor, or the start whenever you confirm rupture of membranes, and we're going to treat them every 4 hours until they deliver. The antibiotics of choice are penicillin or ampicillin. If the patient's allergic, then the doctor may opt for vancomycin, clindamycin, or gentamicin. Complications of presentation. Fetal malpresentation. So the position of the fetal part in relation to the maternal pelvis is what we're talking about here. The most common position that we're going to find the fetal head in when we're checking her cervix is left occiput anterior and right occiput anterior, meaning the back of the head is aligned at the right or left of the patient's pelvis, okay? The most common malposition is occiput posterior, meaning the baby is facing the front of the patient's pelvis. So we call that sunny side up. So when the baby's born, they are actually looking at the ceiling, okay? What's wrong?
The PowerPoint is different.
Oh, is it?
Yeah,
Oh.
it changed slightly.
When did you print off the PowerPoint?
Yeah, mine's right, but I
If you
printed mine
if
this
you printed it
morning.
off before about 4 o'clock this morning, it's wrong.
Oh, awesome, okay.
So just
I
to
just
follow
tweaked it
along
just a
with
little
her,
bit.
sorry guys, the one that you had was from, the previous one that was gonna be taught to you guys, but basically what I did was I gave the PowerPoint to Miss Nash from Miss Surratt, and so she added some different things to it.
But all this
So,
information
yeah,
is found in your book.
yeah.
Okay,
Y'all
I
can
didn't
still
pull any
find
extra
everything in your book, you
information.
just may have to.
If there
write
is
it.
something extra that I've added that is not for your testing, I will tell you, okay? Everything that I'm talking about here is gonna be found in your book, okay? The most common malposition is occiput posterior, so sunny side up, so the baby's being born facing the ceiling. That's a very difficult delivery for mom, okay? Occiput transverse also creates a difficult delivery as the fetal head is turned completely to the side. A lot of times those babies just will not descend properly. You keep checking them over and over and you're noticing that this fetal station is still very high, they're not dropping down into the pelvis, you're having a lot of issues getting that baby to come down. And nursing interventions to help kind of combat that would be a lot of position changes with the mom, turning her to her left, turning her to her right, using different methods. We have things called peanut balls. Some of you who've done your rotation have seen that already, where it's literally a blow-up ball shaped like a peanut, and we use that in between the mom's legs and do different types of positions to try to rotate the baby around and get the baby to come down properly. And they work really well, really well. Malpresentation refers to the part of the fetus presenting first to the pelvis. So ideally, we want the head presenting, cephalic and vertex, meaning head down, crown leading. Breech presentation is when the feet or the buttock present first. This is the most common malpresentation. Most times a mom is gonna know prior to delivering that she's got a breech presentation, but it does happen where you find breech presentation when she's already in labor, okay? If she's been confirmed breech presentation prior to laboring, her doctor may attempt something called an external cephalic version. This is where the doctor will actually externally manipulate the fetal parts to turn the fetus in an attempt to give her a trial of labor. So he's using his hands on the outside of her belly to turn the baby around. It's not a comfortable procedure for a mother. So generally what we do is we have them under epidural anesthesia in the operating room. We have our operating room fully ready for a C-section because complications can occur when you're trying to turn a baby, including drops in heart rate, decelerations. So you gotta understand when you're manipulating that baby, you're manipulating their umbilical cord too. So it can be a little risky, but if the patient and the doctor agree, we may try it, okay? If it's not successful, or if the patient or physician refuse the procedure, then a cesarean will be scheduled. Non-vertex cephalic presentations. These include cephalic presentations other than the vertex. So this isn't breech, the head is still down, but the baby's presenting with a forehead presentation, eyebrow presentation, a face or a chin presentation. Neonates born with face presentations have significant facial bruising, edema, skull molding. Tracheal trauma may occur due to hyperextension of the neck. It can cause problems with resuscitation. Face presentation with the chin are more likely to be successfully born vaginally. So you can see here, I put the types of cephalic presentation. I think on your original slide, this was combined. I made it its own slide so you can see it a little bit better. Vertex or occiput presentation, number 1 forehead presentation. Number 3 is when the baby has that hyperflex neck presenting with their eyebrows. And number 4, they're presenting with their face. A lot of times when a doctor checks and finds this, they're gonna move to a C-section. They're not gonna risk the injury of these babies being delivered, especially number 3 and number 4. Because it can just be, too much trauma can occur. Continuing with complications of presentation, we're gonna talk about shoulder dystocia. So obstruction of the fetal descent by the shoulders after the birth of the fetal head, causing the fetus and the shoulders to fail to deliver. Okay. Shoulder dystocia is a medical emergency. Turtle sign is often the first sign of the shoulder dystocia. So this is when the head is born, but the cheeks of the newborn are resting on the mom's introitus. So every time you push, the newborn turtles back and the head's kind of like pushing up against her. It's kind of a sign that this baby's shoulders are stuck somewhere. It's not allowing the baby to move forward out of her pelvis. There are multiple interventions that we do to relieve the shoulder dystocia, and these figures are also in your book, but I'll go over them here. So what we want to do first when we are thinking that a shoulder dystocia is taking place is we want to lay her completely flat, okay? Lay her completely flat, and we want to perform McRoberts maneuver, which is hyperflexion of her knees. So pull her knees all the way back, okay? We want to hyperflex the knees, and then we're going to apply suprapubic pressure. So that's where you take your fist and you're gonna apply it right into her pubic bone to try to get that shoulder to come up under her pubic bone and release so that the baby can be born. If that hasn't worked, you're gonna move on to Rubin's maneuver, which is applying pressure on the fetal shoulder by manual exam with the hand. So the physician is gonna be doing this, okay? It's not gonna be you unless for some reason you're delivering this baby by yourself, which hopefully not. And then you're gonna try to deliver the posterior arm manually with your hand. If that has not worked, Gaskin's maneuver is the next one. You're gonna move the patient to her hands and knees. This can be difficult if the patient has an epidural and they're not able to move well. Wood screw maneuver would be the next attempt to rotate the fetus until the posterior shoulder becomes anterior. If that hasn't worked, the doctor is gonna try to fracture the fetal clavicle to reduce the shoulder diameter. That hasn't worked. You move on to rescue maneuvers. Zavanelli maneuver, very dangerous, very difficult. And that's simply pushing the head back into the vagina to deliver via C-section. That does not work well at all. Very difficult to do. If that doesn't work, they'll do an abdominal rescue. So they'll make an incision into the uterus and the fetus is manually rotated into an oblique position to hopefully deliver vaginally. If there's no luck with that, the last would be an incision made through the pubic bone of the mother. Your face. Yeah, it can be very traumatic.
Which ones have you had experience with, Ms. Nash, with?
So for me, I've had a few shoulder dystocias, but generally McRoberts and suprapubic pressure will get the baby delivered. I've never had to go this deep into a shoulder dystocia. I know it has happened, but never. I pray that it never does. But my next slide, I'll show you. This happened last year. This was in Atlanta, Georgia. The baby's death was ruled a homicide by the physician after suffering a broken neck during delivery at Georgia Hospital. The medical examiner's office said Ross's baby died from fracture dislocation with complete transection of the upper cervical C1 and C2 spine and spinal cord due to a shoulder dystocia, arrest of labor, and fetal entrapment. The medical examiner said pregnancy-induced diabetes, so the baby was obviously big, and premature rupture of membranes was a significant condition contributing to the baby's death. The baby, who was named after his father, was delivered at full term. This was the big deal.
Was this a complete decap?
Yeah, this baby was decapitated.
So did the article go into more detail, kind of
It
about
did,
what
so
all
there was
happened?
numerous articles about this that had lots of different information, but when I got down to, when we all heard about this story, cause the whole labor and delivery heard about this story. What happened was she was pushing for hours, so there were signs that she probably did not need to go on. I think 4 hours worth of pushing. And the head delivered and the shoulders got stuck. And they went through all of these maneuvers but could not get the baby to deliver. And the doctor was pulling too hard on the baby's head
Oh,
and caused this break in the neck. So the baby was deceased but still stuck in the mother. So they took my mom to the operating room and they had to decapitate the baby to deliver. The body via C-section and the head vaginally.
oh,
I know that's terrible.
So was it blown on it manually or like with a vacuum or forceps or?
I'm sure they tried all of those maneuvers. I'd have to read the whole court document, but I'm certain the doctor probably tried all of those things. What probably needed to happen much earlier on was a C-section, long before they got to delivering the fetal head.
So let's say it's a proper, like, what is the proper procedure for this, if this happens, like, does the baby die, or?
If this
there's-
doesn't happen,
If the head is not decapitated, the baby is stuck, the head is out, the body's in, what happens?
the baby will typically die. A lot of times when you're getting down to rescue maneuvers, your baby's probably, if it hasn't already, getting pretty close to being deceased, unfortunately. Yeah, that's why it's a medical emergency. You gotta get this baby on as fast as possible. And it doesn't take, it feels like forever when you're in a situation like this, but like I said, like the McRoberts and the suprapubic pressure, we're talking 30 seconds, but it feels like 5 minutes you're doing all of these things. So this is a very unfortunate case. That physician's probably gonna lose her license.
I wonder how they got the mom
Go
to
to prison.
agree to that.
They did.
They
That's the
did.
problem.
They did.
That's the issue,
You wonder how what?
How they got the mom to agree to that?
they did,
So there's a lot more to this story that makes it even worse. The parents didn't even know this baby was decapitated. They swaddled the baby and showed the parents the baby, and they didn't know until they reached the funeral home. The nurses and physicians withheld the information.
They did like affect the baby or anything? What?
What do you mean they sutured it back?
No, they just kinda
They
laid
just
it
kinda,
there.
they swaddled it, they put it in a position to where you couldn't take it. Yeah. I don't know how they did it, but they did not inform her. The physician said she tried to inform her and that every time she would try to speak with them, there was a lot of anger and she couldn't tell them. I don't know how true that is, but they didn't know until the funeral home told them.
Was this a big hospital or a small hospital?
Honestly, don't know which hospital it was, but
I feel like, were they not?
it's, I don't
I
know.
think it's.
I don't either, I'll be honest with
It
you.
says the medical center is, Riverdale, 13 miles south of downtown Atlanta.
They could have gotten if they were.
so Google it.
Yeah.
And if you're ever in Atlanta having a baby, just don't
Right,
go there.
just don't. Yeah, even as labor and delivery nurses, we're very confused at how something like this occurs. I mean,
At what point
this
do
is
you like
horrific.
advocate for the patient and be like,
Enough.
stop?
Yeah. Yeah, as a nurse, that's your responsibility. Sometimes you have to make, I think we talked about that, and sometimes you have to make those hard calls and say, hey, look, this, enough is enough of what we're doing here. It's time to make a change. We need to do something different. I was explaining to the group in the last, clinical rotation about the chain of command. If you feel like your doctor's doing something unsafe, it is perfectly okay to tell them, I'm not okay with what you're doing. This is dangerous, and if we don't make a change, we may need to initiate the chain of command. And the chain of command means going up to the chief of and basically telling, I'm telling on you. We're gonna do something different or I'm telling. And we'll get them in here and make a change. And a lot of times initiating the chain of command will make them stop doing what they're doing. It's a hard thing to do as a nurse, but sometimes it's necessary.
This is a great ethical case.
Yeah.
Right, it's
You know, talking about read the whole court document, have they gone to court on this?
I
You know?
believe so.
Okay.
Yeah.
So, you know, one thing that probably would have come out during the trial, they probably would have questioned every nurse that was involved in this.
Oh,
And
yeah.
that would have probably been one of the questions. You know, if you were the nurse, let's say you were the nurse,
Yeah.
what did you do to
Yeah.
advocate for your patient? Okay, well, why didn't you? What, you know, what did you not do? What could you have done? So, yes, the doctor lost her license more than likely. If not, it's probably a miracle, but what about the nurses?
Mhm.
And so one thing you guys always have to understand too is that who do you think that doctor, now, I mean, she's the one who did the decapitation, you know, but who do you think she could have tried to blame a lot of stuff on? Exactly, exactly.
Mhm.
So you always have to remember, you're sitting in this classroom, you know, how long is it taking you to get to this point? You know, what have been your struggles, what have been your, things that you had to overcome, things that you've not gone to birthday parties or whatever.
Right.
And look how quick your license could be gone.
Yeah.
So,
You will absolutely be called for something.
yeah, so you have to speak up, you know, and remember, you know, it's not just the patient, it's the patient and the baby, so you have two patients.
Right. Yeah, she's right. In fact, we had, a similar, well, not a similar situation, but a physician was being, questioned legally for a shoulder dystocia not that long ago, and they called the nurse in and said, why didn't you call for help? That was one question they asked her. And after that, our, management team actually placed a question in our delivery record that said, call for help, yes or no. Simply because of that. Because she did ask for help, but it wasn't documented anywhere. And we always reach out, right? We're gonna hit the call light and say, can I get some more hands in here? But where was it documented? So then the lawyers are gonna pick that apart. Why didn't you call for help? Well, I did. Where?
So
I don't
if
see
you-
it.
Okay, so if you do call for help, you've got to make
You
sure
have
to
got to
document
document it, yeah,
Not documented, not done.
that's right, everything.
I don't care if you
Didn't have
say
to.
up and down, I did, and everybody else says you did, it's not in that record.
Yeah. Yeah, this was unfortunate. Alright, intrapartum procedures. So, first up, episiotomy. This is a surgical incision of the posterior aspect of the vulva made at delivery. It is not performed as often as it used to be. Typically, we're gonna see episiotomies be performed if a patient is judged to be at risk for a 3rd or 4th degree laceration. Or if our baby's compromised, so if the heart tones are showing non-reassuring fetal status, so we need to expedite delivery, or for a shoulder dystocia. That's another reason they would cut an episiotomy, to try to make more room to get the baby out. Other than that, we don't really see our doctors cutting episiotomies very much anymore. It's just not, really great practice. Because the risk includes just a small episiotomy can extend into a 3rd or 4th degree laceration. Okay, so bleeding, infection, and perineal injury with future births can occur from an episiotomy. So typically, we just let whatever's gonna happen, happen. And so we let patients tear naturally. Forcip-assisted delivery. A forcip is a stainless steel tong used to assist delivery of the fetus in both vaginal deliveries and cesarean sections sometimes. In vaginal deliveries, patients are still expected to push while forceps gently guide the fetal presenting part out. If forceps do not help expedite delivery, a doctor's gonna move to a C-section, okay? Complications of forceps include scalp and facial lacerations, eye trauma, intracranial hemorrhage, nerve damage, and skull fractures. Maternal complications include damage to the vulva, vagina, urinary tract. So as a nurse, it's really important, we wanna assess the patient's ability to void postpartum, after a forcip-assisted delivery. Another option to assist delivery would be vacuum assisted suction device applied to the fetal head, and it aids in delivery. Most newer physicians prefer this method. I'd say the physicians that have been around in the last 10 years. They've been trained on the vacuum and not on the forceps, okay? Older physicians were trained with the forceps. So, vacuum is associated with a lower patient injury. Potential complications include intraventricular or intracranial hemorrhage, cephalohematoma. I feel like that's the most common. They tend to get like a little blood pocket on the top of their head from that suction of the vacuum. Brachial plexus injury can occur, laceration of the fetal scalp. Questions about that? So here's a little question. Is the following statement true or false? After an unsuccessful birth using forceps, the provider will likely attempt a vacuum-assisted delivery. False. They're not gonna do both. Absolutely not. Cesarean birth. A cesarean is the delivery of the fetus through an incision in the abdominal wall. It is the most common operating room procedure in the country. So we have scheduled and unscheduled C-sections as well as elective C-sections. So reasons for scheduled would be if she had a C-section before, she's a repeat, or she's having a C-section because she has breech presentation. Unscheduled would include failure to progress, a failed induction, non-reassuring fetal status, the baby's not tolerating labor, uterine rupture, cord prolapse, fetal malpresentation. And elective is just what the patient wants. She's decided she wants to have a C-section. So we are going to do neuraxial anesthesia. Spinal or epidural anesthesia is used for C-sections. So the patient's awake, she just can't feel anything from the breastbone down. General anesthesia can be used for cesareans as well. It's just not the preferred method, but we will do it in an emergency and if the patient's condition prevents being able to use a spinal or an epidural. So like if she has low platelets or some sort of clotting disorder that won't allow her to get an epidural or a spinal, then we put her to sleep.
So do y'all know the difference between a spinal and an epidural, anesthesia wise? And how they're, like when do they do them and things like that? Can you kind of share with
Yeah,
us?
so a spinal is what we're gonna use for C-sections. Okay, that's gonna be a heavier block than epidural placement. The main difference though between a spinal and an epidural is when an epidural is placed in labor, there's a catheter that's placed in the patient's back that's going to give them medication for the rest of their labor. It's gonna keep them comfortable until the end of labor. With a spinal, it's like just a one shot and gets them numb for their surgery and then it wears off. But with epidural, we want them to stay comfortable, so we have to have a means to keep them comfortable, so they thread a catheter. Similar to your IV, it goes on a pump, and the anesthesiologist or anesthetist is gonna program the pump to run at a certain rate and give them medicine for the duration of their labor. And then they can come in and give them boluses if they need it, if that medicine is not keeping them comfortable. And different hospitals do different things. I know some places will have like a button for the patients to push, they can give themselves their own bolus. Of course, they can't just keep pushing, it'll walk out. And then, like at where I work, you just call them if you need a redose and they'll come do it themselves.
And when they do, sorry.
Go ahead, you're fine.
When they do the, spinal versus the epidural, do they do the spinal when they're in, like, just kinda waiting, or do they wait and do the spinal when they get into the OR?
So for a C-section, once we take that patient to the OR is when we're gonna do the spinal. So whenever her surgery time starts, the first thing we do is the spinal. So she's gonna be sitting on the operating room bed, give her spinal, we're immediately gonna lay her down for her C-section after that. She's gonna get numb really fast. Sometimes you can't even get them laid down properly before they can't move their body anymore. So that spinal kicks in quick. The epidural does not kick in like that. So in labor, when you're in your labor room, after the anesthetist places the epidural, it takes about 15 to 20 minutes for a patient to get comfortable with an epidural. It's gonna start kinda at their toes, they're gonna feel warm and tingly, and it's gonna start to move up their body until their belly is numb and they no longer feel contractions. But the spinal is much quicker and it's a heavier block. A lot of times their chest muscles get real numb and they get real anxious because they feel like they cannot breathe. You felt like you couldn't breathe. They think that they're not breathing. But what it is the muscles of the chest are numb, but your lungs are still working. So you have to kind of reassure them, tell them it's okay, let them know your oxygen saturation's really good, it's 98%, whatever. You're breathing, you have a blood pressure. Cause some patients, especially people who have anxiety, are gonna have a big problem with that feeling.
And mine was emergent, so I didn't have anybody telling me anything.
Yeah.
It's just like, hurry.
You were just on your own. Yeah, and epidurals typically don't set up that heavy. So you're not gonna get that feeling of I can't breathe. Now, some people struggle with the numb legs, they don't like that either, but it's not gonna set up so heavy that you can't feel, you don't feel like you can breathe. So, but it takes away the contractions, that's the beauty of that.
And when the spinal wears off versus the epidural, the spinal's a lot quicker to wear off.
Yeah, and
So they may be fine, and then all of a sudden they're like, hey, I'm hurting.
I'm hurting bad, I need pain medicine now. Yeah.
And sometimes
so-
it's before they ever leave, if
Right.
you've got labor and delivery, they move them to postpartum. So
Right.
before they could ever get them over there.
They're already hurting. Oh yeah, some of them are hurting before they leave the operating room. It just depends on the patient, how fast you metabolize through that medicine. Me personally, I take forever. My epidurals stay with me till the nighttime. I'm just numb. But some people start breaking through that medicine fast, and they need pain medicine before you can get back to your room for recovery. So, just totally depends on the patient. And, it's a surgery, and that's what a lot of patients, and I explain this to my patients, I educate them preoperatively. This is a major surgery, a major abdominal surgery. Unfortunately, the idea that they're awake makes them forget that. You're gonna hurt after this surgery. And when that spinal wears off, it's gonna be a rough 24 hours for you. So we need to keep some pain medicine going, some pain medicine on board. You guys have seen in postpartum, and you'll see the ones that have it on. Some of these patients wait too long to take their pain medicine, they try to go without it. Then we're playing this game of catch up, trying to keep them comfortable, and it's just kind of a nightmare. So I really educate my patients on staying on top of your pain medicine, taking it almost round the clock in the first day, rather than waiting until you think you need it, because you're gonna need it. Just take it. Not so much with a vaginal delivery. A lot of people with vaginal deliveries don't really need a lot of pain medicine. It totally depends on the patient. Some may be okay with a little Motrin here or there, a little Tylenol. Just depends on the patient and the injury, the extent of their laceration if they have one. So that's the difference between the two. C-section patients are a little more difficult to take care of, okay, because they have major surgery. So, I can say at our hospital, our anesthesia has gotten accustomed to giving Dilaudid before you even leave the OR on every C-section patient. It's helped tremendously. They give them 2 milligrams IM of Dilaudid, and that helps get them started. Even if they're still numb, that medicine's working for you later in that first hour, and then you're not rushing around trying to hurry and get their pain under control. So it makes it nice for us. That actually came from one of our physicians. He wanted to start that, and now everybody's doing it, so it's great. So preoperative care, when a patient arrives for her C-section, we are going to do some lab work. We need to get a CBC. We need to do a type and screen. We're going to look at her platelet count. That's very important. We want to make sure she can clot her blood before we do spinal anesthesia, okay? Because we don't want her bleeding. And also the C-section. That's important to know for a C-section. She's probably going to get some prophylactic antibiotics, single dose antibiotics given 60 minutes before incision time. She's gonna be wearing some SCDs on her legs to help keep the blood flowing. We're gonna monitor the baby up until the time of the surgery, so we're gonna make sure baby's good. Things can happen. You never know what you're gonna get when a patient walks through the door. We've had cases where it's a normal scheduled C-section, a patient walks in, put wanna make sure we know where the placenta's at. That's important, and we're gonna get to that in a little bit too. We wanna make sure fetal position is assessed. That just helps the physician, so that they know what they need to do as far as delivery. So when we get her into the OR, we're gonna put her spinal in, we're gonna lay her down, we're gonna put her catheter in her bladder. That's very important. We want her bladder empty throughout this surgery, okay? We're gonna scrub her skin with chlorhexidine or iodine. Prior to scrubbing her skin, we'll clip her hair if she hasn't been shaved. And then once the scrub dries, we're going to drape her for surgery. And then the doctor will start his procedure. And then the wedge, you see that a lot of times we will displace, and that's really, I'll say at our facility, but the anesthesia decides whether they're gonna do that or not. Some do it and some don't, but displacing the uterus, rolling the patient off of her vena cava can help make her feel better during the surgery. So she's not laying on that giant vessel, which can drop her blood pressure and make her feel terrible, okay? Some people do not tolerate laying flat when they're pregnant. I know I didn't. That was not good for me. And then after delivery, we're gonna monitor her like you would do any other surgery patient, okay? We're gonna keep her in labor and delivery for 2 hours. We're gonna monitor her blood pressure every 15 minutes. We're gonna make sure her temperature's good. We're gonna monitor her O2 sats continuously. We are going to monitor her uterine tone and her bleeding from her vagina. We're gonna start breastfeeding in the labor and delivery room. We're gonna keep her catheter in until she can get up and walk, okay? So about 6 hours after anesthesia is when they usually have their legs back and they can actually start moving around. Like some sooner, some later, it just depends on the patient. But it is very important to encourage your patients to walk. They need to get out of the bed, okay? You're increasing your risk for blood clots if they are not moving. They need to get up. Prime example, I had a patient a couple weeks ago who was refusing to get out of the bed. She just didn't want to. And you know what I did as a nurse? I documented that. I educated her over and over and over, and she just didn't do it. I cannot force her to do it, but I can educate her. And then I'm gonna document that I did. Because if something happens, and she does have a blood clot, it's all charted that the nurse did everything she needed to make her get up. I even put her STDs back on her legs and said, well, if you're not gonna get up, you're gonna wear these. And then she took them off. And I documented that too. So,
Was it her first, was it her first C-section?
It was. And I get it, but I said, the more you move around, the better you're gonna feel. That's a hard concept to get when you're hurting, and I understand that. But most patients, once they start really walking around, they'll see you do feel better out of bed. I do. She just wasn't buying it. Most wounds are closed with sutures or staples, and they're gonna keep those for about a week after delivery. And then they need to just increase their activity as tolerated and avoid heavy lifting and squatting.
Ms. Nash, are y'all doing, I know at one point in time they were doing like, some type of catheter for like local that was staying within the C-section incisions to help with pain, are they doing that?
Is that when Dr. Brown was doing his pain ball?
I think so, okay,
They got rid of that.
okay.
Yeah, I don't think it was working quite as well as they were hoping. Yeah. Yeah, it was like a little tube that, it had a little purse with the ball in it, had medicine in it, and it was like supposed to be running medication up under the incision, but they got rid of it.
What are y'all doing to help with, incision pain? What are some interventions that we can do besides pain medications?
Really, so I've noticed that a lot of physicians are using wound vac now on a lot of patients, and that has made a difference. Yeah, I think it's this, it's called a Prevena, and it's this skinny little device they're putting right over the incisions. It sucks down just like you would any other wound vac, and it stays on for 7 days. Patients tend to really like it. It helps prevent infection But by the end of their first day, we're gonna remove that dressing and leave it open to air, okay? Getting that off early and just assessing it often, making sure that it's free of infection. Okay. Vaginal birth after cesarean. So this is attempting a vaginal delivery after you've had a previous C-section. So, not all physicians will agree to this. The risk of uterine rupture is small, but it is a risk not worth taking by some doctors, okay? Currently in my facility, we have 2 physicians who will attempt this. Physicians must be in-house. That's the biggest deterrent to a lot of doctors is that if a patient is in labor, they can't leave. They have to stay. Now their offices are considered in-house because they're on the campus, but they can't go home until the patient delivers because it is risky. So patient can be administered oxytocin and she must sign a consent in addition to the hospital consent. She has to sign consent to be back. Her previous C-section must be attributed to non-reassuring status or breech presentation. She must have a low transverse incision. She cannot have a classical up and down incision. It has to be the low transverse. If she's had close spacing, I don't know why this did like this. If she has close spacing pregnancies fewer than 6 months between the end of one pregnancy and the beginning of the next, she does not need to be trying to be back. If she's had more than 1 C-section, or she's over 40 weeks gestation, or she's had a uterine rupture, she does not need to be trying to be back, okay? So, when a patient desires a VBAC, she needs to have a conversation with her physician. They need to nail down whether or not this is gonna be worth it or not for her, and whether the physician's going to be willing to take on the risk. Anybody know why a VBAC is risky?
Cause you have all those courses.
Uterine rupture?
Yeah. Everybody got it right. Uterine rupture. So you have a scar on your uterus, okay? And that scar, that incision was closed and created without a pregnancy. So the baby was delivered via C-section, it shrunk down, they created the incision, scar is there. Now the uterus is stretched out again, it's gravid, it's big, that scar is stretched. Contractions are pushing on the scar, creating tension. That can rupture the scar. And that is a medical emergency. And a lot of doctors just say, I ain't doing it. It's not worth it for my license. It's not worth it for what can happen to you and your baby. I'm not doing it.
So these are for patients that have had a vaginal, but maybe think, I mean, a cesarean, but next time want to try vaginal.
Yes, vaginal birth after cesarean. So you wouldn't want to do this if the last time you had a C-section because you didn't dilate. Chances are you ain't gonna dilate again. Does that make sense?
So why would one even wanna do this? Is it just like a personal desire to
They
deliver
just wanna
vaginally?
have a vaginal delivery. Or maybe their C-section was horrible for them. Maybe the pain was just too much and.
I'll say from my own personal experience, cause I did try for a VBAC my second time, and if I have a third, I plan to try again. There's that moment where they automatically give that baby to you and you have like that skin to skin moment, you feel all these emotions and they just took mine away, my husband held it first, I didn't get that, it was just, for me, that was like a big thing that I just wanted to experience.
And for women, there's just that golden ray of sun surrounding the vaginal delivery. It's just the thing that most of us want. Because it's what's natural to us, you know? And so, it's like, a lot of women have to have a C-section, it's sad, it's not what we planned. We know it's possible, but it's just not what was in the cards or what we thought should be happening. So a lot of women will say, I'm willing to risk it, you know, I'm willing to take that risk. And if their doctor's in agreement, then they do it. And I've seen them be very successful, plenty of people have had successful VBACs. But there's certain reasons why you shouldn't. You know, there's certain stipulations, and you gotta be smart enough to say, whenever you're within those reasons to say, okay, this just isn't for me. But if it was non-reassuring fetal status, your baby's heart that's the reason you had to have your C-section? Okay. Well, that wasn't your fault, that had nothing to do with your body. If your baby was breech, when this time it's not, then that would be a reason to try. Does that make sense? So it all depends on the situation and your history. Okay, here's a question. So after reviewing a patient's prenatal record, the nurse determines which of the following is a contraindication for vaginal birth after cesarean? C. Vertical incision. Never gonna happen. Okay, that up and down incision creates way more tension and increasing the likelihood of a uterine rupture. And here we go, uterine rupture. Okay, uterine rupture. This may occur in patients attempting a trial of labor. So TOLAC is another acronym, which would be trial of labor after cesarean. Hear feedback a little more often. It can occur in patients with a scarred or unscarred uterus, but more likely in patients with a uterine scar. So the signs that your patient's uterus is ruptured, you may have a sudden development in a category 2 or category 3 tracing. So your baby's heart rate has changed. Something is wrong. You had a beautiful heart rate before, and now something looks suspicious in the way that your baby's tolerating labor. You may have maternal hypotension and tachycardia. Why is that? Because your patient's bleeding. Okay? Weak contractions. So the uterus has lost its tone because it's ruptured. So your contractions are pitiful now. Loss of fetal station, meaning your baby's moved up in the pelvis. So you check your patient and the baby's like gone. Like whereas before you maybe check her and she's at 0 station, now you're at -3. Like where did the baby go?
Because the contractions are not there.
Right. Or the baby has left the uterus. It can be in the abdominal canal. Yeah. Vaginal bleeding. And another one, and I'll just tell y'all this is not for your test, because I did not see it in your book. Referred shoulder pain is a huge classical sign of uterine rupture. I don't know why, but a lot of patients who rupture their uterus have pain in their shoulders. It's one of the first things. First uterine rupture I ever experienced as a brand new nurse. Is there something? She was non-English speaking, and she was laying in her bed, laboring away, and she literally sat up and grabbed her shoulder. That was what she did. And she ruptured her uterus. We had one last year, or the year before, and it wasn't quite as dramatic as that, but she kind of kept telling her nurse, my shoulders hurt, my chest hurt, I hurt up here, something is wrong, something feels wrong, and her uterus was ruptured. Yeah. So they have pain, that's hot, hurt. This is a medical emergency. They need an emergency C-section right away. Okay, I have a little video to show y'all real quick about uterine rupture.
A midwife faces possible revocation of her healthcare license after the state health department repeatedly cited her and fined her for violating midwife regulations. In one home birth case last December, both mom and baby died after having to be rushed over to the hospital. The widower now going public with his tragedy and is sitting down one-on-one with ABC 15 investigator Melissa Blazes, pushing for accountability.
28-year-old Jordan Terry, an ER nurse in Stafford, was expecting her third baby last year. Already mom to a boy and a girl, this child was to be the tiebreaker.
Be like, don't look at the ultrasound. We'd have to like close our eyes, and I'd try to peek, and she'd get mad at me, and I'd get mad at her because she was trying to peek, and so it was fun.
Jordan wanted to become a midwife herself to better serve her rural community. So this time, she and her husband Parker hired a licensed professional midwife to assist in a home birth. Their baby's due date, December 2023.
We had this vision where birthing pool in the living room underneath the Christmas tree with the stockings around.
Their midwife, Sarah Kankowitz, posted on her business Facebook page that she specialized in VBACs, that's vaginal birth after cesarean section. Medical professionals say VBACs can be higher risk, in part due to the potential of uterine rupture. But Jordan and Parker agreed to move forward after talking to Kankowitz.
And she gave me all the right answers. She gave me exactly what I wanted to hear. And her plan of action was that she's there to look for red flags. She's there to protect and watch out for the safety of the mom and baby.
Parker did not know before his wife's due date that Kankowitz had been investigated by the state health department multiple times during her 4 years as a midwife. Regulators finding deficiencies, failing to follow state midwifery rules during 2 prior births. And she's repeatedly faced civil penalties, fined 5 times for not submitting required midwife reports detailing the care she provided to clients. Jordan went into labor at home on December 17th. Parker remembers after the midwife had arrived how Jordan started to lose color in her face and then lost consciousness.
And that was actually her last coherent words was call them. And Sarah clarified, call the ambulance, ? And Jordan said, yeah.
Instead of celebrating the birth of their tiebreaker baby, Mac, Parker held his stillborn son for a few minutes. Jordan was airlifted to a different hospital, but also died of a uterine rupture.
The safety and the health of mom and baby is the most important thing. I said I wish I knew then what I know now, but hindsight's 20/20 and it just kills me.
What does accountability look like to you?
Ownership.
After reviewing the circumstances of Jordan's and Mac's deaths, the state issued a notice of intent to revoke Sarah Kankowitz's license, saying in violation of Arizona code, the licensee did not immediately alert emergency medical services once the client began to visibly decline, did not check vitals for client and fetus as required, did not monitor dilation as required, and provided services to a client who had a previous cesarean section with complications, adding, accepting a client with these risk factors for a home birth increases the risk of complications and can contribute to avoidable maternal and fetal demise. Kankowitz is scheduled to meet with the state health department for an informal settlement conference on Wednesday. Parker awaiting the results to hear if state regulators will revoke her license.
At the end, it's just kind of a slap on the wrist, but here I am with no wife and losing a newborn child.
Parker Terry says after posting his story on social media, he received an outpouring of support, including from some other midwives. And he says now they're discussing how they can together advocate for stronger regulations on midwifery right here in Arizona. It's something that we will be reporting more on in depth in the coming weeks. ABC 15 also reached out to that midwife, Sarah Kankowitz, by phone. She said she had no comment about what happened.
How did her regular OB doctor, did they not encourage her, I would not do this because of?
Probably
Didn't tell her.
Because it says she had complications.
I'm saying she said she had previous complications, I was just wondering did
She
they not
probably
feed her
just didn't
symptoms?
go back to her OB and found a midwife.
I don't know, I
Moved
don't
on
know.
like that. Yeah, you can do that. Your OB's not gonna reach out to you. They're just going to go do what you wanna do. I mean, a lot of people change doctors, so if she doesn't ever come back, they'll just assume she just went somewhere else. So, that case actually came through to labor and delivery too. We heard about his wife, from one of our physicians. He put his story on TikTok, the whole story, so you can find him, Parker Terry, if you don't wanna watch his entire story. He tells the entire story from what happened start to finish, and it's very sad. And he videoed the whole birth. So everything is on video. And that midwife failed to do a lot of things. He questioned her multiple times about the state of his wife. Said she doesn't look good, something's wrong, her lips are blue, and the midwife kept saying she's set up. She was not a candidate for VBAC. Okay, first of all, no one is a candidate for VBACing at home. Ever. Ever. You do not VBAC at home. If you're gonna choose that, you do that in a hospital where they can respond quickly if something goes wrong. This is very sad.
Is that out of the midwife's like scope of practice? I thought they were.
She should have never taken her as a patient. That was not good. And actually, when I was looking for that video, I saw another one that said that she's moved and is practicing in another state. I don't know. I don't know what's going on, but she is something. Okay, umbilical cord prolapse. This is a condition where the umbilical cord is gonna precede the fetal head in the birth canal. The fetal head is then gonna put pressure on the umbilical cord, compressing it and stopping blood flow. The first sign typically of a cord prolapse is a change in the fetal heart tracing. You may see some bradycardia or some variable decelerations. A prolapsed umbilical cord is a medical emergency. You need to do an emergency C-section. Okay? There is no way to fix that. So typically the nurse is gonna find this herself. It happens during labor, generally. And when you go to check your patient vaginally, you're gonna feel the umbilical cord in her vagina. If you go check your patient and you find an umbilical cord, you're gonna keep your hand in her vagina, okay? You're gonna push up on the fetal head and try to prevent the head from putting pressure on the cord so that you can keep the blood flowing through the cord and keep the heart rate up until you can get the baby out, okay? So as the nurse, our interventions in this moment is gonna be hit that call light, get some help in your room, okay? Because you need more hands, because you're not gonna be able to do anything. You're gonna be stuck right there with your patient on her bed. So hit your call light or have your family member go get some help, okay? You need help. And the other nurses are gonna come in and they're basically, you're gonna have someone call your doctor and tell your doctor, I have an umbilical cord prolapse. And they're gonna come running for you. And then you're gonna have the other nurses start taking everything off of your patient and running you to the operating room. That's basically what happens. That's the gist of it. You need to do an emergency C-section. What I have done in the past, before I hit the call light, unless my baby just looks really horrible and I don't have time for this, but my personal cord prolapse story, I did have time. My baby's heart rate was having few little decelerations, but it was okay because I was holding pressure off the head, or holding pressure off the cord. I'm gonna look at my mama and I'm gonna say, hey, what I have right now is not good, okay? The umbilical cord has fallen into the vagina ahead of your baby's head, and this is an emergency, and we need to do a C-section right now. I'm gonna tell her that calmly, okay? It's so important to educate your patient so that they don't feel like everything is chaos and they don't know what's happening to them and they had no idea what went on and they felt like they were out of the loop. So if you can, take 20 quick seconds and say, hey, this is what's happening. This is what needs to happen next. I'm about to hit this call light and it's about to get wild in here, okay? Okay, we're on the same page, let's go. And then you're gonna get a rush of people in your room. But at least they know what's getting ready to happen, okay? And you're gonna take that patient to the operating room, and the primary nurse who's holding pressure off the baby's head stays in position until the baby's born.
So what is the difference between the feel of a umbilical cord versus?
So the head is hard. You're feeling the bones of the skull, just like how your head feels. That's what a baby's head feels like. The cord is like squishy and like gelatin-like. It feels different. You know something ain't right.
There's a definite.
Something's in here that doesn't belong. Yeah. And the cord pulsates. You can feel the heartbeat of the baby in the umbilical cord. Because your physician will ask you, do they'll ask you.
Okay.
So you do a quick 10-second check, it's 120, doctor, it's fine. I still got a good pulse. They're gonna be communicating with you, yeah. Now sometimes it can be difficult to feel that pulse, cause let me tell you something about a cord prolapse. Your hand is getting squeezed by those contractions. Contractions are so powerful, and I never quite knew how powerful they were until I was involved in a cord prolapse, and my hand came out purple from those contractions, killing my hand as I waited for that baby to come out. I mean, cramped up, yeah. So feeling the pulse was not really happening for me, I'll be honest with you, because my hand was dying. But you're gonna keep your hand in place. You're gonna hop on the patient's bed with her, okay? Y'all are gonna ride to the operating room together. They're gonna drape you under the drape with the patient. You're staying with her, with your hand in her vagina. Once the baby's delivered, you're free to come out. It's very true. I did this not that long ago, guys. Actually, I was the charge nurse, and my nurse called out with a cord prolapse. So I assisted her down to the operating room. And the patient had not been in labor very long, so we hadn't really done much for her. She ended up having to go into general anesthesia because she didn't have a epidural or anything in place. What I had to do was put her fully in with the nurse's hand in her vagina. That was fun. I stayed as sterile as I possibly could, but I don't know how sterile that was. I did the best I could, but yeah, that was a new experience. I've had 3 cord prolapses in my career, and that was the first time I ever put Foley in like that. And that baby did well. The baby did fine. The baby came out and was okay. But it's all about getting your people in there and getting to the operating room fast. Okay, amniotic fluid embolism, another medical emergency. An amniotic fluid embolism is caused when amniotic fluid enters the maternal circulation, and it's associated with maternal mortality rate of 20%. It is a rare and devastating condition. The amniotic fluid containing fetal cells enters the circulation, and it can occur during pregnancy, labor and delivery, or postpartum. It is unpredictable and unpreventable. Okay, symptoms typically occur during labor, and your first symptoms are usually respiratory arrest and cardiac arrest. An emergency C-section is indicated if the patient has not been delivered. Clinical manifestations include cardiogenic shock, respiratory distress, and coagulopathy. There is no treatment for this.
Can this happen, let's say, woman's pregnant, they find out that the baby is no longer living, and then, you know, physician allows natural things to happen with that. Can this happen with that also? Like with the?
Yes, you're asking if the baby is demised?
No, the baby has passed. The doctor said, oh, well, your body's gonna reject the baby. Does this happen? Can this happen with that?
Yeah, because it's when the amniotic fluid enters the fetal circulation. So even if the baby's passed, you're still gonna have fluid. Is that what you're asking? Yeah.
Just to see if this is possible.
It is, and this is a very sad thing because like I said, there's no real indication as to who it's gonna happen to. It's rare, but it does happen, and it's devastating. So interventions, if your patient's experiencing an AFE, you're gonna call for help, right? You're gonna get help in our room. If it's prior to birth, we want to place our patient in the sideline position. We're gonna continue monitoring the patient's O2 stats, heart rate, respiratory rate. If birth has not occurred, we're gonna keep monitoring the baby. She's probably gonna need a central venous catheter. We need to continue to infuse fluids, medicines, blood draws, arterial catheter. She's probably gonna need if she's still conscious. Vasopressors, norepinephrine, dopamine, blood products, and prepare for an emergent delivery if it's before birth.
So is the risk minimized a lot more if you schedule like a cesarean since they're?
Nope, it can happen during a C-section and after. This is probably one of the scariest things that can happen to a mother because it's unpreventable and unpredictable. I'll be honest with you, I said a lot of prayers about this with my last pregnancy, just because you just don't know. My last pregnancy had been a nurse for the longest amount of time, so I knew the most, and I'm like, just right here, I'm bringing this one to God. This right here, this is information not on your test, and it's not in your book, okay? This is actually some evidence-based studies I was looking at. This has been going on for about the past 3 or 4 years. Some physicians and anestheticists have been investigating the use of 3 medications that can help combat intrauterine fluid embolism. Did you have any raised on the Okay. So AFib should be investigated in women who experience sudden cardiorespiratory collapse during labor. Obviously, there's other things that can cause that, pulmonary embolism, heart attack, things like that. But we always want to consider AFib, okay? Patients experiencing an AFib who develop cardiac arrest should receive immediate cardiopulmonary resuscitation. Oxygen and supportive ventilation, vasopressors, and intratropic medication should be included in patient management, and that's what we were reading. A perimortem cesarean should be performed within 5 minutes of cardiac arrest with AFib. So here's the part where I've been researching, and our anesthetist, I found this out through the anesthetist at my hospital. Treatment used in conjunction with traditional advanced cardiac life support protocols include the use of atropine, ondansetron, and ketorolac protocol, and they call it AOK. AOK is thought to work in amniotic fluid embolism by reducing pulmonary vascular resistance, increased serotonin and thromboxane levels during AFib cause vasorestriction, platelet activation, and worsening pulmonary hypertension, leading to cardiovascular collapse. These medications can help combat that. This is actual evidence-based practice in the works, okay? Lots of studies are being done on this right now. So much so that our anesthetists have had these medications stocked in their anesthesia boxes. They want them at the bedside because they're gonna use these if we have an AFib, okay? So for the purpose of your test, we're saying there's no treatment, okay? But I wanted y'all to know there are things being worked on to try to help these women because the fatality is so high. So here's the question. A patient gave birth 1 hour ago and suddenly experiences cardiac arrest. What should the nurse do next? All of the above. Do it all. Okay. And there's a little video about AFib.
In 2020, there were an estimated 3.6 million births in the United States. Perinatal complications are numerous. One of the most pronounced and severe complications that an anesthetist can encounter is that of amniotic fluid embolism.
Amniotic fluid embolism, or AFE, is a rare obstetric complication that occurs in approximately 1 out of every 50,000 pregnancies. Although the risk of AFE is low, its uncertain etiology, varying symptoms, rapid onset, and high fatality rate make it one of the most challenging obstetric emergencies to manage.
An amniotic fluid embolism is caused by entrance of amniotic components into the maternal blood. Amniotic fluid components include things such as meconium, squamous cells, lanugo, vernix, and other fluids.
The risk factors for AFE include induction of labor, multiple pregnancy, cesarean section, and advanced maternal age greater than 35 years old. For an amniotic fluid embolism to occur, a break in the fetal amniotic membrane at the onset of labor must occur. This leads to the amniotic fluid entering ruptured maternal vessels located in the uterine muscles or the intrauterine cavity.
seen in AFE are caused by mechanical obstruction of maternal microvessels by amniotic materials and by anaphylactic reactions caused by the liquid components of the amniotic material present in the lungs, leading to pulmonary vasospasm, inflammation, and platelet aggregation.
The resulting anaphylactic reaction is believed to be caused by vasoactive substances such as bradykinin and histamine and procoagulant substances found in the squamous cells of the amniotic fluid.
Initial symptoms of AFE include tachypnea, diaphoresis, anxiety, hypertension, chills, and coughing. As the embolus disrupts maternal circulation and gas exchange, maternal hypotension, pulmonary hypertension, and right-sided heart failure contribute to fetal hypoxia and subsequent fetal bradycardia. Symptoms will progress to cyanosis, hypotension, cardiac arrest, fetal distress, seizures, hemorrhage, and coagulopathy.
The AOK protocol is a series of 3 medications, atropine, ondansetron, and ketorolac, that are utilized to interrupt the devastating pathology of AFE. Atropine, which is a muscarinic antagonist, assists in both pulmonary and cardiac protection during AFE. It inhibits the activation of parasympathetic muscarinic receptors, which prevents bronchoconstriction and bradycardia.
Ondansetron, or Zofran, which is a serotonin antagonist, eliminates the ill effects of serotonin-stimulated 5-HT receptors, which causes pulmonary vasoconstriction during AFE.
Ketorolac inhibits thromboxane A2 and prostacyclin, which are both necessary components for initiating platelet aggregation. Therefore, ketorolac is beneficial in the treatment of an AFE through its inhibition of thromboxane and subsequent platelet aggregation. This is deleterious during an AFE as these effects further compromise maternal circulation and gas exchange in the pulmonary system.
Standard doses for AOK protocol include atropine 0.2 to 1 milligram, ondansetron 8 milligrams, and ketorolac 15 milligrams to 30 milligrams IV push. The AOK protocol should be utilized as quickly as possible when amniotic fluid embolism is suspected. By utilizing the AOK protocol, a provider can take an early and vital step in managing amniotic fluid embolism crisis. We hope this video has been a beneficial educational tool to you in your practice.
So again, that's not on your test, but I wanted you guys to know that there's something happening out there, evidence-based, that can hopefully help these women in this crisis, because it's devastating. Okay, retained placenta. This is when the placenta has not been expelled within 30 minutes after birth, okay? It's just kind of stuff, it's not wanting to deliver. Usually you see this with early deliveries, so like a patient's delivered less than 30 weeks. You don't really see it very much at term because the hormones of the body are gonna naturally cause the placenta to detach, but a lot of times when a patient wasn't ready to deliver yet, their body will have a little bit of a hard time. So the doctor's gonna apply traction on the umbilical cord, so kind of pull on it a little bit while they massage the fundus to try to get it to release. They may use TXA or oxytocin to help facilitate contractions, and if that fails, they may need to manually extract the placenta or go into surgery and do a DNC. Morbidly adherent placentas. These are placentas that did not adhere properly to the uterus. So the first picture over there on the left-hand side is a normal attachment. That's how we want our placentas to attach, okay? The second picture is a placenta accreta. This is where the placenta attaches to the myometrium, which is like the muscular layer of the uterus. It's a little deeper than it needs to be attached, okay? The second is placenta increta. This is where the placenta is actually penetrated into the myometrium. So you can see it went further down into the uterus. And the placenta percreta, which is the most severe, is the chorionic villi penetrated the myometrium, and it can grow risk for catastrophic bleeding. So when you're ready for that placenta to detach, it's gonna shred because it's too attached. So then you're just pouring blood and it's a devastating situation. So a lot of these patients already know they have this type of placenta because it was diagnosed via ultrasound. So the doctors are gonna schedule a C-section. We're not doing vaginal deliveries with this. It ain't happening. We need a controlled environment, okay? They need to be type and matched. We need to have blood ready and available, okay? They may need a hysterectomy, especially the last two. Those are probably gonna be a planned, what we call C-section with hysterectomy, okay? Placenta procreta may need partial removal of their bladder. It's catastrophic, guys, if it's not diagnosed before delivery. For some reason, sometimes these things get missed. Then you have a patient in a vaginal delivery, everything's fantastic and wonderful, her baby's here, and then the placenta delivers. And everything breaks loose because you have a devastating postpartum hemorrhage. And you can't figure out why. What's going on? Why is she hemorrhaging so badly? It isn't until the doctor takes her to surgery, because that's usually what has to happen in a situation like this, because you're not gonna stop the bleeding, because the placenta has just shredded, and they find that she had a morbidly adherent placenta. Perinatal loss. Stillbirth occurs in approximately 6 out of 1,000 pregnancies that reach 20 weeks gestation. Perinatal loss is the delivery of a fetus with no signs of life. We also call it a fetal demise. Medically speaking, a fetal demise or a stillbirth is gestation over 20 weeks, okay? So any baby that's born without a heartbeat less than 20 weeks, medically it's considered a miscarriage or a spontaneous abortion. Spontaneous abortion is what it's gonna be called on paper, but don't ever say that to your patient. Nobody wants to hear that they're having a spontaneous abortion. We always call it a miscarriage. The rate of stillbirth goes up after 40 weeks gestation due to the decline of the placenta. Other risks are adolescent deliveries, patients over 35, patients of African descent, unmarried patients, congenital anomalies, intrauterine growth restriction, multiple gestations, male fetuses, and maternal disease. Prevention of perinatal loss includes taking folic acid before and during pregnancy. We want to screen for syphilis and treatment, and any other STDs too. Any STD can cause you to go into labor early, so we want to make sure we're getting treatment. Screen for and treat hypertensive disorders and maternal diabetes. Address modifiable risk factors like smoking, alcohol, and obesity. Screen for fetal growth restriction. Close management of post-term pregnancies, and we want to make sure our patients are getting good prenatal care. So if you're taking care of a patient who is coming in to deliver a stillbirth, we want to make sure that we're communicating warmly and gently with the patient, because these patients are going to come in to labor. They need to deliver. So they're going to be induced, or they're going to have a C-section. If that's, like say they're a previous C-section, they're going to need a C-section again. We want to be kind to them. We want to avoid a lot of medical terminology, use clear language, validate their emotions, provide continuity of care when possible. We want to respect their needs. Treat the stillborn infant with respect. Respect the patient's preferences for seeing or holding their baby. So, you know, my mantra for taking care of these kind of patients is like, pick up whatever they're putting down, right? When they walk through the door, I take note of everything about their affect and emotional state. We go from there. You'd be surprised how well most patients handle these types of situations. I'm gonna talk about what we're doing today, okay? We're having an induction. I'm not gonna be overly excited for them, but I'm gonna talk to them like I'm talking to you. And like I talk to any other patient. I'm gonna educate them on the process of the day. And most of the time, we have a good day. Good periods of sadness throughout the day. We laugh, we joke, and then we have moments of sadness. long as you're caring and kind. And then involve them in every step of the process. And it's okay to be sad with them. It's okay.
They, like, still lactate.
They do need lactation consultants to come
The body
and
still
help
goes
them
through
understand
all
how to,
the motion.
they can stop or they can pump and they can donate their breast milk. They have options for that, so it depends on what they wanna do. But lactation would be the best people to call to help them navigate that part. So you wanna get the same people in the room that you would if they have a live baby. They need to see lactation, they need to see social work, okay? We're gonna call the social worker, she's gonna come and talk to them about funeral arrangements. She's gonna come in and, we're gonna call the coroner, we're gonna call LOPA, that's part of our procedure. We have to call them both within 2 hours of delivery. As far as the baby, we're gonna collect memorabilia such as photographs and footprints and refer the patient to support providers. And I've actually added some stuff, again, not on your test, but this is just what we do at my facility. This is Rachel's gift. This is a nationally accredited program. A mother had a baby who was stillborn back in 2006. She was 35 weeks pregnant, and she got into a car accident, and her baby's name was Rachel. Due to the loneliness and grief that she felt during that time, she decided to start a nonprofit organization, and she called it Rachel's Gift, to offer bereavement services to mothers experiencing pregnancy loss. She started this in 2008, and since then she has grown this program. Like I said, it's nationally accredited. She goes from hospital to hospital certifying the nurses in her program. I'm certified. And she serves over 20 states. So what she does is she provides these keepsake boxes that we give to our mothers. Comes with a little teddy, a card for all the nurses to sign, a gown to dress our baby in, a blanket for her to take home. There's a container to do like a lock of hair, footprints and handprints, things like that inside of this box. But the biggest takeaway from Rachel's Gift is that the follow-up. The parents fill out a form that we take back from them. She follows up with these people for a year. Every few months, she's gonna send a card to them, and she's gonna call them and check in on them and see how they're doing and if they need anything. And if they need more support, she'll arrange for them to have more support. Because what she said when she came to certify us is that when women are having a stillbirth, a lot of times they're in a state of shock. Even though they're looking at you, talking to you, having conversation with you, they're not quite there, okay? And you cannot educate someone who's in shock. You might think you are, but you're not. And what happens is about 3 to 4 months after this delivery, the shock wears off. And then they're left in a lot of immense emotional pain, and they're all alone and there's no one to support them. So Rachel's Gift is a way to continue that support throughout that first year to help these mothers get through the grieving process and the families. She has all kind of stuff on her website for dads, grandmas, grandpas, siblings, things like that. So.
Quick question.
Yeah.
You said you call LOPA, so is any of that stuff viable?
I honestly don't know the full scope of what local will take and what they won't take. Now, if a baby is demised in the womb, I would think not. I would think maybe if a baby comes in, we do chest compressions, like, for example, a car accident. I've had a patient come in from a head-on collision, delivered the baby 37 weeks. It was born alive, but there was like 40 minutes worth of chest compressions. Maybe that baby would be a candidate.
Why is protocol?
They want us to call for every single fetal demise.
So what happens when a baby dies? Who makes the decision how the baby is born?
The doctor and the patient. So, you mean via C-section or labor? Or, so if she's never had a delivery, or if she's had a vaginal delivery before, it'll be vaginal. That's just, or like her just terminating it is what you mean?
Well, no, the baby died inside, so I'm just curious, who makes the decision of how the baby is expelled?
It's the doctor and the patient. had a previous C-section, then she'll need a C-section. We treat it just like any other, C-section. We won't let her labor for fear of uterine rupture, because she's gonna have to contract. It'll be between them, and they'll send us the order and tell us what to do.
So how long do they have with the baby?
They can keep their baby for as long as they want. So we've had patients take their baby to postpartum and find out that baby's still with them the next day. I mean, eventually there's a cutoff, right? You gotta take the baby eventually, because you gotta go home. You can't take the baby home with them. But most patients will give up their baby before they leave labor and delivery, I find. But, some of them will take them to postpartum. So we bathe the babies, we dress the babies, we put lotion on the babies. We do everything to the babies that we do a live baby. Make them look pretty and beautiful and all the things. And let mom have them, and they can hold them and love them, and we keep a crib beside them. A lot of parents will just put them in the crib and just have them there. They don't really necessarily even are holding them, they just want them by their side. And they'll take them to postpartum like that, and they can keep them until they're ready and done.
Well, then we have to soak them in Epsom salt.
Yeah, that came from Rachel's gift. We did not do that before her coming to teach us. So she taught us about placing the baby's body in saline water, that the salt, the baby will absorb the salt, and it actually restores their color, plumps them back up, and makes them look new again. Because the babies start to lose their color, they start to turn purple, they start to sink in, they start to look real bad after a while. She taught us that if you place it in a container of saline, it restores them. And you can keep doing that over and over,